All right, so as people are kind of jumping in, I'll just kind of quickly go through some introductions. I'm Ashley Campbell. I'm the managing editor for IJSPT. And again, this is the first of many to come IJSPT and Northeast Seminar Journal Club. So we're really excited to be doing this tonight live. We even have one of the authors of one of the articles with us tonight. So they'll be introducing themselves here in a minute. Just a few quick housekeeping things before we get started. Those of you that didn't have a chance to download the articles or anything like that, when I pull my slides down, I'll jump in the chat box and put the link to the Google Drive where I have the PDF saved. So you'll be able to access those and take a look at them, download them, print them off, whatever you need. CEUs, we are very fortunate that in partnership with Belmont University here in Tennessee, we're able to offer. Now, again, it would be only in the state of Tennessee, but based on your various states or locations, you may be able to get some carryover on an hour of CE credit for participation tonight. We are using something that is brand new to us to try and auto send those certificates after participating in the webinar. So bear with us. Hopefully those should auto flow out. We'll know if it doesn't, and we will handle that accordingly after this first go. So we're going to work out all the kinks on that. And then just some quick thank yous to all of our sponsors. Without our sponsors, we would not be able to provide what we do with IJSPT. So as most of you know, we are open access, so free to all of you to read. We are also free to publish in, which is kind of a rare breed of a journal these days. And that wouldn't be possible without all of our wonderful sponsors supporting us and helping to back that financially. So we just want to make sure that we thank all of them, as well as our headline partner for this particular thing with the Journal Club, Northeast Seminars. And then last few reminders, we are hosting our second annual IJSPT Research Summit at OSET in Boston this September. So we are still accepting abstracts, and all of this information is available at ijspt.org as far as guidelines for submission, and those are due July 15th. And lastly, just a reminder, the IFSPT is holding its Fourth World Congress in August of this year. So any information regarding that you might be interested in is also available at ijspt.org. So without further ado, I'm going to turn it over to our lead host, Rob Mansky, tonight. I'm going to let him jump in and kind of start the intros of the rest of our panelists. Like I said, I'll get the link to those articles posted and we'll get this show on the road.
Great. Awesome. Thank you, Ashley. Well, it's really exciting to be here with everyone tonight. Mike and I have been talking about doing something like this for quite some time now. We actually talked about it way back last year, and we just really finally got into doing it. And so this is our very first one. We hope everybody on likes it. We hope you tell your friends about it. And as we continue to do this each month, hopefully it will get bigger and bigger. The plan here today is to talk about two different articles. Luckily, we have one of our authors who was able to get on with us tonight, and I'll introduce him in just a moment. But I'm Rob Mansky. I guess I'm the host of this, and I have a co-host I would like to introduce. Hopefully a lot of you know him. If not, I'm gonna let him tell you a little bit about himself. But I'm from Wichita State University. I teach in academics, but I also practice clinically still. Even though I work in just academics, I still practice clinically and see, shoulder, elbow, knee type patients constantly. So we're gonna go through these articles. We're gonna talk about some stats and some research methods, and we're gonna talk about the actual articles themselves and how we can relate them clinically so that hopefully everyone can gain some knowledge from these different articles. So first of all, I'd like to introduce our co-host, Phil Page, and I'm going to let Phil tell just a little bit about himself, and then we'll go down the line with the rest of the people on tonight.
Thanks, Rob, and thanks to the Journal and Mike and Ashley for putting this on and inviting me to be a part of this. So one of my passions is article review, critical analysis, and if you haven't checked out some of the things we've done with the Journal in terms of webinars on how to do that, it'd be kind of helpful if you had some time, and Ashley can maybe put that in the chat, where to find the links to the stuff we've done as a journal to really increase your, ability to critically appraise articles. Tonight we have some really good articles, and we'll talk about some of the great things and some of the not so great things in both. And none of the stuff that we talk about is meant to be too critical of anything. As we go through this, we need to be able to have open discussions, civil discussions that are respectful and educational more than anything. So that's what a journal club really should be about. It shouldn't be about just reading something and going, hey, this is the finding of the last sentence of the abstract and the conclusion, which is a lot of clinicians tend to do that. And they kind of skip over the part that I like to specialize in, which is kind of looking at the statistical side of some things and the methodology behind it. So hopefully, Rob and I will tag team with our guest every week that we'll introduce in just a minute. That Rob will introduce Bob Mangine. But anyway, real quickly, I am associate professor and research director at Franciscan University DPT program in Baton Rouge. I have been a sports academy member for however many years, not as many as Mangine, but probably half of that. So without further ado, I'll turn it back to Rob, who can then introduce our next guest.
Thanks, Phil. Thank you for your introduction, Phil, and thanks for bringing that up. This is really meant to be just an open discussion and dialogue with us. If you have questions, I didn't mention that earlier, but if you have questions, you can put them in the chat box, and we're going to be monitoring those and hopefully able to have time to ask some of those of the different authors or of us. But this is really meant to be just open. It's meant to be really casual and relaxed, not uptight. We're not here to try to offend anybody. My vision of this is really just like, the four of us are at a meeting and maybe we went to a bar and each have had a drink or two and we're talking about research. I mean, that's what we're wanting with this. It should be really relaxed and casual, and we hope you enjoy it. So it's a pleasure to introduce our co-host or our guest host, I guess. Phil's the co-host. Bob is the guest host. And he told us earlier before we went on that he probably will never be asked again, but I'm guessing Bob will be asked multiple times in the future to join us, and hopefully he'll grace us with his presence a little bit more. But Bob, for people that don't know you, can you introduce yourself and tell a little bit about yourself to everybody?
Well, thanks, Robin. Thank you, Phil, for inviting me to be the guest host. My background is I'm a PTATC going on now 45 years. 46 years. I've been a trainer for 47 years, and I've been the past president, or whatever it's called now, for the sports section. I still have a hard time calling it whatever we currently call it. I have a 7-year activities as the president of the section, and actually it was my board that started the whole specialization process right after Lynn Wallace tendered his position as president. Currently, I serve with Novacare Rehabilitation in the role of clinical sports residency programming, and I also serve as the head basketball trainer at the University of Cincinnati as an associate athletic trainer for sports medicine at the university. My background is primarily knee research, and I want to thank Mike in advance that in his article, the oldest reference is a 1991 reference from Mangine, Noyes, and Barber. So, and that's going to stimulate my end of this conversation as far as the whole structure of the evolution of how we've been trying to put people back to play post ACL, because we still don't have the answer.
Thank you, Bob. Great introduction, and that's why we wanted you on here today. These I think both of these articles fit perfectly in your wheelhouse to help us discuss these, and hopefully everyone can learn a little bit of something from these. So, without further ado, our first article we're going to discuss is single leg vertical hop test detects greater limb asymmetries in horizontal hop test after ACL reconstruction in NCAA Division I collegiate athletes. And I would like to thank Michael Zarro for joining us today. He's the lead author on this paper. And so, Michael, tell us just quickly about yourself, and then please tell us, just give us a quick kind of rundown of your article, why you did it, what you found, and then we'll start some discussion after you're finished.
Sure. Thanks for having me. Just want to say thank you to everybody for putting this on. It's really exciting that we're getting a national journal club going based on some great articles here. So my name is Michael Zarro. I'm an assistant professor at the University of Maryland, Baltimore, in the PT program. I'm also the team physical therapist for both University of Maryland and College Park. That's just a little bit down the road, and then University of Maryland, Baltimore County. So my role is teaching and conducting research for 2 days a week, and then 3 days a week I'm seeing patients in our affiliated athletic departments as team physical therapist. So my interest in this topic came sort of at the beginning of my career. I was working in hospital-owned outpatient PT practice. I was getting to see a lot of patients after ACL reconstruction, and some of the surgeons and colleagues that I was working with, we were all doing things like this horizontal hop testing, and I was finding that for the most part, the patients that I was working with were doing very well. And as I transitioned into working in college athletics, I continued to find that most patients were doing well on these things, as well as doing well on strength testing with 1 rep max. And so this was a while ago, before I had access to things like handheld dynamometer, force plates, biodex, and some more, I guess, advanced testing. But kind of anecdotally, I was noticing that a lot of these student athletes that I was working with, despite having 95 or higher limb symmetry indexes on the horizontal hop testing, and probably similar scores on things like 1 rep max testing, maybe reaching some of their baseline scores in the weight room that maybe they had some pre-injury baseline data on. I just kind of had this gut feeling that there was something, left on the table, that maybe there were still some lingering knee deficits. So a few of the strength coaches that I worked with were using jump mats, doing like double leg counter movement jumps to kind of weekly for athlete readiness or monitoring. And so I thought, well, maybe I could start looking at a single leg jump and maybe include that in our, post-injury testing battery. So after just kind of playing around with that anecdotally, I was kind of identifying that some of these athletes who otherwise looked like they were doing outstanding based on 1 rep max testing, horizontal hop testing, I was still picking up, some minor deficits with the single leg vertical hops. That's when I started collecting the data and starting to kind of put the some background work into a project such as this that I did over the last handful of years.
Great, thank you. So I guess I'd like to start the conversation with just asking the question, maybe to Bob, to Michael, you, or even Phil. Yeah, we've been doing, Bob, when did you start doing functional testing? Back in the 80s?
Yeah, Rob, if you look at the evolution of trying to move more toward a functional testing pattern, it was probably more starting in the middle 80s, maybe 84, 85. And you may recall guys like Gary Losey, Dale Daniels, Mary Lou Stone. We would get together and discuss what type of activities we would want to try to evaluate, because in the 80s, we were really hung up into isokinetics. Mm-hmm. So, you had to have that isokinetic score that said this, and then it's like, oh, you're magically ready to go back to play. You're magically ready to go to whatever. And finally, we started looking at different hop tests. When we started to look at the horizontal hop test and the lateral hop test, the evolution of that is quite simple. We know when you tear your ACL, you tear your mechanoreceptor in the ACL. And we know that there's a deficit neurologically in your neurocognitive behavioral activities. And we wanted to be able to start to get a feel for when that would come back. And in the clinic, you needed something simple. It's easy to do it on the field. I just, put 4 cones out, do cone drills, do this, do that, and I could see it on the field. And then everybody started to get hung up on symmetry. Was it 15%? Was it 10%? Was it equal symmetry? And we kind of said, no, it's not the symmetry. When you're vertically moving or horizontally moving or laterally moving, it's how you come down. And we came up with a concept called spatial awareness. And that is, as you're taking your body through space, can you visually or tactily, upon landing, control your center of mass? Because it was George in 1997 published a paper, I think it was out of Germany, in which he took 8 ACL reconstruction, no, 8 ACL deficiencies, 12 ACL reconstructions and 12 normals, and both the deficiencies and the reconstructions showed the same change in compensating the center of mass. And so we published a paper on gait in which we saw changes in the center of mass on gait. The reason we picked the horizontal was as you're running, you're projecting forward and you have to decelerate and you have to put the foot in the ground. And if you can't get that foot in the ground right, you're going to be screwed. And if you looked at some of the functional tests out there, we wanted to go lateral. So why did we end up going time top? So we went horizontal, single leg, distance, can you control your body? We then said we need to know what you can do over a given time. So we took the 6 meters and timed it sort of like a power value. And then we finally said both of those. So our ACL deficiencies could do that 67% of the time. So we weren't sensitive enough to rule out ACL deficiencies. Because remember, back in the 80s, we were still trying to say the rule of thirds. A third of these people don't need surgery. And we wanted them to fail in the clinic, and most of them did, and then we would go on and do the surgery. The reason for the crossover hop is real simple. Realize the lateral compartment is your backup to knee stability once you tear your ACL. We discovered that the hard way back in the 70s and early 80s, where we took the IT band and did ACL reconstructions, and they came in 6 months later with varus instability. And we said, oh my God, what did we do? And we had to go back in and reconstruct the lateral compartment. If you do a lateral hopping, you have to go into a varus opening position and then rethrust back over. And that's when the ACL deficiency said, man, we ain't comfortable. It had nothing to do with asymmetry. It had to do with the quality of the land and control your center of gravity. Because these kids will land with their arms out, their arms this way, their arms that way, and they have to, what I call, nail the land. And we have gone, and I love Mike's paper, by the way. I love the paper. And we have gone to vertical hops as well with force plates, because our coaches also have at the University of Cincinnati, we still have the jump mats. So we've been playing with them more with basketball, and we have the other sports. But I love the fact it gives you that elevated position. It gives you that load, explode, and land. And I don't know if you saw the latest article on Sparta jump systems. The military just came out with an article in, oh my Lord, I'm old. I can't remember, it's just not that long ago, in which they looked at vertical land on the Sparta system and saw no correlation to injury prediction or return to activity. So we've gotten ourselves into, what's the new one called, force decks through the Vlad system. And now we're playing with that with Kevin, and we're looking at a lateral hop. We're looking at what Mike just talked about, a vertical hop, and we're looking at a forward hop. And so we're trying to combine the data. And then, of course, when Hewitt came out with his paper with Nige, whatever they say it, and said, everything you guys do doesn't really matter because none of it can predict return to play. And it made us have that warm, fuzzy feeling inside.
Yeah, we all did.
Wasted 45 years of data collection just to be told that nobody's ready to return to play. And in reality, let's say this, when I do all my tests in the clinic, it just tells me that I can get them back on the field or back on the court. And then what I do with them in practice is really the most critical. The beauty I like about Mike's paper is it's what I call a closed loop system. Mike does the rehab, Mike's doc does the surgery, Mike's trainers interact, getting them back on the field, Mike's strength coaches do that work, and he's got a great success rate.
Everything's really consistent, yeah.
Right, and that's where at our university, I just went back because we were playing with it, my last 20 years of ACLs, if I can find them all, and I've had like one re-tear in the last 18 years. Because we have a closed loop system where we control everything with it. And, you know, like I said, I love the fact that what Mike's done is validating what we've done at the university level. The question is, how do we get that into the community patients? Because if you read Mark Paterno's paper, you know, they looked at jump lands, they looked at isokinetics, and they took on all comers. And as what was his re-tear rate, like 38%, Phil, when we read that paper, or he presented that data in Colorado Springs some years back. And then, what I'm sure what Mike would show is he probably doesn't have any re-tears because he's got complete control of the kid from the time that they have the injury to the time that they return. So overall, I think this is a valuable paper to look at and really look at these numbers. And I just don't get hung up on the asymmetry as much as I get up on, boom, that quality of that land and the control of that center of mass.
You guys didn't look at any of that type of stuff, did you, Michael? You weren't looking at force plates with this study. Oh, you're on mute.
Sorry about that.
That's okay.
So with this study, no, one of the things that we were interested in the study was what's a simple way that we can get this information out into the community, as Bob said, right? And so when we think about the average physical therapist, our new grads, I mean, I teach as well, and we think of all of our students every year going off to clinic. Not every clinic has biodex force plates. Most of our DPT students are not trained in the nuances of using force plates, and so distance hopped over a tape measure, distance hopped using something like a simple jump mat, or even there's iPhone apps that can pretty reliably calculate that. These are things that I think are fairly simple, and so when you think about what many clinicians are using as part of their return to play decisions, which might just be manual muscle test and
a lot of
knee
people,
range of
it's very
motion
minimal.
and just time.
Yeah.
And so if we can, and we can't go so far and expect everybody to be using force plates because that's not realistic or cost effective either. But what are some low hanging fruit? And so a variety of hop tests have been shown to be very, very helpful. This is just another one that you can consider using. It's certainly not meant to be the end all be all, but I definitely think there is some value, and that's why one of the reasons we wanted to share. Bob brought up a pretty good point about our closed loop system, and I think that's definitely something that I personally see value in what I do. We included that in the paper as one of our limitations, though, right? That we can't generalize this data to all patients, across the country. I mean, we were looking exclusively at Division I athletes, provided rehabilitation by myself and one other person, and that's not to say that's going to be the exact same rehabilitation that somebody might receive at a different clinic. That might not be the same surgery provided by a different surgeon. So just that's something for the audience certainly to keep in mind, that this was a fairly narrow population that we looked at, which is unique to to our role in college athletics, but that's not the same as what everybody's seeing and doing.
Yeah, and you guys did a fair number of functional tests too. So I guess another question that I was wondering about, and really it's just more clinically than maybe exactly your paper, Michael, but how many functional tests do we need to do on people before we try to determine whether they're ready to go back to sport? I mean, we could functional test the hell out of people, right? And we could do 20 different functional tests, but what is the number that we need? Or is there, maybe we don't even know the number we need, do we? Probably, Bob, we don't know for sure yet. Okay, we're not curing everybody, so maybe we don't know yet.
No, I don't think we know yet, Rob. I mean, I think one of the problems we run into with any testing, objective testing, is it's like, oh my Lord, I'm back to 95%, or I'm back to this level of asymmetry, and I'm only 6 months out from surgery. Why can't I go back to play? And yet you look at these studies that the longer I can stretch it out, the better chance they have of not re-tearing. Kevin and I just sat on a panel down at the football meeting, and that was a question from the audience was, gee, if they come back to normal functionally by 6 months, should we let them go back to play? And our response was no, just find some more functional tests.
Yeah, exactly.
Until you get out to a year. Because what my job is, once I'm done in the clinic and I take them back on the court or onto the field, is I want to increase their level of difficulty on the field. And that is, I'm trying to put the kid in non-contact drills. Then I'm trying to put the kid into contact drills. Then I'm trying to put him in a scrimmage. Then I'm trying to put him in a game. So as we go through that process, we continue to do our functional testing clinically, just to continue to see if there's a change in those functional tests as we take them through the practice progression or the scrimmage progression. And again, I think, I really like Mike's paper to demonstrate again, if you can keep this system to where your physician, your PT, your training staff, and you have a great strength coach backup system you will have a high rate of success. Okay. And I think too many people are just out there marketing themselves and just take one patient here, one patient there. And I think that's quite a disservice. I mean, if you look at what Russ told us, that was in Colorado Springs right after Mark, they have a group of physicians, but they control the PT post-op, and they control the strength coaches that deal with them, and they control the athletic trainers that deal with them. And they reported a 2% failure rate at 2 years out, which is pretty effing pretty
good.
darn
That's really
good. Sorry, Phil, for for that level of community patients. What the direction we're going in now is that neurocognitive side, and we just started working very closely with a company out of California, in which we're doing QEEGs with our functional tests and our gait patterns, and we're seeing an immense change in brain waves. We were very fortunate last time they were here. One of our girl lacrosse players tore her ACL while they were here, and the day after the tear, we did, they have an 18 lead system that's sort of like a skull cap, and the brain change compared to the normals the day after an ACL tear is unbelievable. We're in the process of writing it up just to get it out there. And that's where I give Dustin Grooms a lot of credit with trying to do some of this QEEG stuff to show that we're all worried about what's going on at the knee, but what's the driving force that has to respond is the brain. And we had 5 kids with abnormal gait patterns, and when we looked at their QEEGs, they were all messed up.
Wow.
And we're trying to validate some of the things we do. But I think Mike gives us a great point that we can get out there, the clinicians right now. These are things you can do right now that's going to help decide your patient progression.
Yeah. Thanks, Bob. Hey, Phil, do you have any questions? You can either, I saw you saw the one in the chat. You can either ask that, or if you have any others, you're more than welcome to add something that is more important to you than that, and we can ask it after yours. You're on mute.
All right. You had these questions you wanted to ask before. I don't know if you want to hit those.
No, I don't need to hit them all. I just came up with some just in case we had time. But
I did think, Michael did a great job too with that concept of having what you see clinically and actually taking it and publishing the paper. That's the hardest thing, is just doing that. So congratulations to you on pulling that together. And the key I want to make sure people understand, and what's great about what Michael did, if you do go back and read the limitations section, he hits on the important things. And when you have a good paper, what you see is that the authors call out the elephant in the room. When you go and read a paper and you look for all the biases and all these things, if that author doesn't address those things that are pretty clear, they might be trying to hide something. I don't think they did that in this paper at all. So just from a statistical standpoint, there was a question on the power analysis. And Michael, you guys did that, which is a great thing. Not many people do these power analyses. There was a question that we were talking about earlier about the numbers that go into a power analysis. I don't know, Michael, did you actually run that yourself, or did you have someone else do it?
So I did that with one of the co-authors. And this is the kind of first paper kind of like this that I've worked on, that I was kind of involved in, like the planning and a little bit of the stats. So I did do that kind of in tandem with one of the co-authors on the paper, the senior author, Kristen Nelson. So I can do my best to answer that question, because I did kind of go through that process with her. But if I have something a little bit off, I apologize in advance.
Oh, no, there was a question of, first of all, congratulations on doing power analysis. You need to do that. And I think you said 14 was required sample size. What you need to do, and I'm not saying you, Michael, I'm saying the audience, right? What we need to do is look at what are the parameters. And you reported a P of 0.05, an effect size of a power of 0.8, which is very standard. The effect size you reported was a 0.8. So just for the audience to know, what that actually means is that your ability to detect this very large effect size of 0.8, meaning that's a standardized difference between the two groups, that margin of error was detectable. The secret here with power analysis is the higher that number is, the lower the sample size you need to find that large effect. So when you want to actually find a smaller, when you need a smaller effect size, when you go down to like 0.5, 0.2, that's when your sample size goes up. So sometimes we may play with that number to get that right number of samples that we want to be able to do the study. What this basically means, though, is if there was an effect size, we usually, you guys know, if we talk real briefly about effect size, the general effect sizes go from 0.2 of being trivial, to 0.5, a moderate, 0.6, and this is all based on Cohen's D values, the standardized mean difference. So 0.8 is a very large, and what you're looking at is the difference between the two jumps, the two hops. If you wanted to be probably a little bit more clinically relevant, then I would probably go down to 0.5, and that would simply just increase your sample size to, I did an analysis, I think it was about 22, something like that. But it's a very small difference. It's just, again, educating on interpreting something in an article on how important it is to do power analysis. And the last thing, and I'll shut up, is the thing that's missing here in these tests, and y'all have hit on it, is the clinical importance. And we use that 10% symmetry. Where is this MCID? Where is the minimal clinically important difference? That's what's missing. And we need to do a lot better job in all of these tests to find out what's clinically relevant. Is it 10% difference? Is it 12? I don't know. So there you go.
We still don't know.
Still don't know.
Yeah. It's so, Phil, it is so, when you get into the clinical side of it, it is so athlete dependent. And I say that because, I had one kid who in 2007 that I allowed, he tore his ACL, MCL, and his meniscus in the fourth game of the season against Miami of Ohio. And that year, unfortunately, we were invited to play in Toronto, Canada, in what was called the International Bowl, the first International Bowl, and I think it might have been the last International Bowl. And in essence, the kid was a senior defensive tackle, and he was 11 weeks and 6 days after his ACL. And like Mike was talking about, he was back to limb symmetry by 8-9 weeks, and I put him back to practice at 9 weeks. And then he played the whole game as a defensive tackle. So I have an N of 1 that I've allowed to play at 11 weeks and 6 days. And yet I can go back to 2 years before him, and I've got a female basketball player who has a very high Beighton score, which I think plays into our success. And it took me 22 months. So, the bottom line is, it is, and again, I liked the fact that what Mike showed was, he did have some minor statistical differences between the different hops, but yet they still were, I thought they were all pretty reasonably graded out there, that you get some people who can return to normal. And I think most of yours were back to normal by 6 months, if I'm not mistaken, or within a certain limb symmetry by 6 months in the article. And I think that returns pretty quickly. But then you got all the other factors like the quality of the jump, the quality of the land, and then can that translate back onto the field? And the kid was able to come back and play after just 2 weeks of flat practice. And I even took the KT1000 with us, and we tested him right before the game, and we tested him right after the game. And darn if he didn't move at all. Yeah. So, again, you can't beat genetics. You can't beat what God gives some of these kids. And sometimes genetics makes us all look like we're rocket scientists.
That's right.
And sometimes they make us all look like a Walmart greeter. So, the bottom line, you take what you get when you can get it.
Yep. Hey, Michael, there's a quick question on the chat asking about if you looked at, or did you account for the quality of their jump? So on their single leg hops, did you somehow account for the quality of how they jumped? Or was it really just the distance or the time on the mat that you used?
Yeah, for the article, we just reported the objective information, which was the jump height and the jump distance. But as a clinician, that's what we're doing every day, right? So somebody can, that's one of the downsides of a jump mat. It just tells you the time between foot contacts. It doesn't tell you anything about how that jump was done, the quality of the movement, the quality of the landing. Now, we did require that they stuck the landing to a reasonable degree on all the hops, and so that does help a little bit. But I'm a clinician just like most others on this call, and so those are the things that we're doing every day. Is we're gathering and we're making those assessments. When somebody's movement quality is poor, whatever we call poor, I mean, that's something that we need to be aware of and work on. And so there might be athletes that can generate very high rates of force development, and they might be able to generate some pretty large jump scores. But as Bob and a lot of others have said, if their movement quality is not where we want it to be or need to be, we need to account for that. So just because we had some athletes on this paper that were doing very well, we didn't say anything about this paper that these individuals were cleared to play solely based on the testing that we did. We were just reporting on some interesting findings that we found. But our return to play criteria is kind of a team-based thing with us, our physicians, our athletic trainers, and strength coaches, and movement quality is certainly a big part of that. So just kind of generating some good objective numbers here is one piece, but movement quality certainly is just as important.
Sure. Well, before we move on to the next, we've spent just about 30 minutes on this topic, but before we move on to the next article, Bob, someone on the chat, can you explain what the QBEG testing is?
QEEG is qualitative.
QEEG, sorry.
Is qualitative EEG, and in essence, we're getting a feel for asymmetries within the brain, and we're getting a feel for interneuron networking. And when you tear your right ACL, of course, it affects the left side of your brain, but we're finding increased activity within the right side of the cortex to make up for potentially some of the decrease in activity on the left side of the cortex. So we're really looking at networking of the neurons. I think our data is, we just started doing it a year ago. The reason we went to that was when we came back from Colorado Springs, when Tim told us that all we were doing wasn't worth anything, and he published that paper. I actually have it, right here with
Nagali, or however you say his name. Yeah.
Yep. And so I said to our neurology people, I said, well, here's the deal. We just got told in Colorado Springs that we have no idea what we're doing and nothing we do works. I said, but the one thing we haven't measured yet, Dustin has tried over in Delaware, I think he is, in which he's tried to look at brain activity with range of motion and things like that. And was there a company out there who could do QEEG, but while they were doing, like we're doing overhead squat, we're doing a gait assessment, we're doing a visual field like with Dynavision and Blaze Pods, and we're actually having them function, and we're measuring the inner networking of the brain with athletes who are acute. Only have, and in one so far, but we have 79 total trials with kids that are in the first 4 weeks after ACL, the second 4 weeks after ACL, the third 4 weeks, and then we tested a bunch of normals who are back to play to see how they compared to the other ones. And I think, to me, we talk about psychomotor neuron training or neuroplastic adaptation, and I think this is our best bet at trying to find out exactly what type of neuroadaptation does occur, because the mechanoreceptor as of right now does not grow back into the ACL. So thank God he has given us more sort of other pathways that we can make up for that.
Yeah, great. Thank you. So with that, let's move on to our next topic.
Hey, Rob,
I
think this might be a quick, easy answer for Michael. Someone put a question in the Q&A for the subject population. Was the average of 7 months post-op targeted, or was it just the average that happened to come out of it? Or was there any time frame post-op that was your goal looking at this?
No, so I tested at intervals that were clinically relevant to me. And so just like everybody else seeing patients, you're a little bit at the mercy of what your schedule looks like and when you have access to the equipment that you want to be utilizing for testing. So that was just the average. We tested people typically beginning at 6 months and then every 4 to 6 weeks following that, whenever I think it's relevant to update the rest of our medical team on how the patient's doing. And then as we approaching return to play, we may test a little bit more frequently if we want some more specific information. But one of the challenges of the college setting is sometimes our students go home for summer break, and so they disappear from me for 3 months. And so there might be a window where I don't actually have access to them. And so I think that's just why this is, purely, clinical data, and I'm a little bit at the mercy of what, the calendar looks like.
Great, thanks.
Thanks, Ash, for bringing that question up. We do have a lot of questions in the chat box, and what we'll do is if we have time when we get finished with the second article, we can go back to those. So can you hang with us, Michael, till we're done, or do you need to leave?
No, I can hang. I might just pop out and check on the family quickly, but otherwise I'll be here. Okay,
just make sure everyone's alive and then come right back. All right, so our next article tonight is the effect of low load blood flow restriction training after anterior cruciate ligament reconstruction. This was a systematic review. It was the senior author on it is Barris. I believe the last name's Koch. But they looked at several articles. There weren't that many articles. That's one thing I wanted to point out once we get started in this. But they found the results of the systematic review indicate that low load blood flow restriction training after ACL reconstruction may be beneficial on quadriceps strength, quadriceps mass, and knee joint pain compared to non-BFR training with non-detrimental effects on ACL graft laxity. However, more obviously, like every study has ever been written, more randomized controlled trial with standard intervention protocols and outcome measures are needed. So, Bob, just in case we have, it looks like we have 77 participants on tonight. And my guess is a lot of them probably know what blood flow restriction training is and why we're using it. But my guess is not every one of those 77 have as much experience with it as you. Can you just briefly tell everyone, why we're using blood flow restriction training for ACL patients, or really for any lower extremity patients you're using them for?
Yeah, I wouldn't limit it to ACL, Rob. We're doing it much more over a broader spectrum of patients, but basically you're using a cuff, sort of like a blood pressure cuff, to control the arterial inflow and also control or stop the venous outflow so that you can increase the amount of blood within the muscle during the exercise, because then you can load only to a 20 to 30% RM. You have a low load applied to a muscle which is being constricted, and yet you're still seeing the effect of that low load while they're exercising, and you do it in different cycles. You can do it through different loads. You can increase your load as you go through the process. So I think at this point there is definitely a major advantage. If I get an ankle sprain now, I'll do BFR on them, within 24 hours after the injury. If we have a shoulder issue, we will do it, at the proximal arm. We've done it for the hip with our hip injury. So I think although this article is looking at ACL reconstruction, I think the concept of being able to control venous flow out and increase the flow into the muscle gets you a greater change within the muscle with less force.
Fantastic. The articles they had, I'm trying to remember here. I think it was six. Was it 6 articles? But three of the articles were from the same study, essentially. So really, it's only 4 articles. And the other thing I found really interesting is that not one of these damn studies were from the U.S. They were all international. So are we behind the 8 ball here with BFR? Phil, Bob, what?
No, I don't really think we're behind the 8 ball. I think a lot of quality studies have come out. I'll obviously point people in the direction of the Journal of Athletic Training from 2021, where a group of us, Dan Lorenz, Lane Bailey, Kevin Wilk, myself, Terry Granstead, Scott Morrison, Paul Head, we published a paper called Blood Flow Restriction Training, in which we looked at the effect of, what is the effect we're looking for? Well, we're looking for obviously the muscle to undergo mechanical tension. We're looking at a metabolic occlusion so that we can get an increased growth factor response. You get a hyponic environment where you have this massive, be careful how I say that, we have an influx of blood with limited outflow, and you can get a fatigue factor faster, which will give you that anabolic signaling. So I think that, a clinician in today's world needs to look at it. I think there is good quality US studies out there that show that, you can achieve in the early phases of post-injury, you're going to get a greater achievement of strength or less of the deleterious side effect of the disc atrophy if you can incorporate low load blood flow restriction. When we started years back, we were very conservative. We would wait 2 weeks to 3 weeks to start blood flow after the surgery. Now we're doing it within 48 hours after the surgery.
A lot faster.
We're doing it with electrical stim. We're doing it with straight leg raises. We're doing it with our mini squat program. We're doing it with our gait training program. So I think, very early on, we can close the chain with an ACL, get them up and doing body weight squats within 2, 3, 4 days post-surgery and use the blood flow restriction program. Because again, because of the increase in the metabolic activity within the muscle, you will see increases they have seen and measured increases in protein synthesis within the muscle system, and they have measured increases in growth hormone that'll occur with the blood flow restriction. So, there are studies that show increased muscle strength. There are studies that show cross-sectional mass increase.
I was going to say mass. Yeah.
Yeah. Yep. And so I think that it's you as a clinician, you need to make sure you undergo some good training and direction. I'm not saying you have to take a fancy course or you have to use a $15,000 type system. Everybody knows I can remember back at Pittsburgh in the 1960s where we would take ACE wraps and the strength coaches would put ACE wraps around the kids' legs as the kids were doing squats. And so what's funny is, like with my patellar tendinopathy basketball players, we found, I'll be careful I say this, we found 2 old 1977, 1976 Nautilus open chain knee extension machines. My strength coach, who's a guru of refabrication, cleaned them all up, and we'll do an eccentric program with blood flow restriction because we know we can do a little lower level force. We can help, we can either bring it up with them and just have them focus on the eccentric phase. And I think it's less of a force on the tendon and makes it a lot easier on the kids to get through their pathology. So I think BFR is far more than just, post-op ACL at this point.
Fantastic. Phil, what are 4 studies enough to do a systematic review?
Yes. So what's interesting is the authors had started trying to do a meta-analysis. That would be the ideal thing, which is to collapse all of the studies together. Part of the problem is the heterogeneity of each study and how they deliver the BFR. As you read in the paper, the studies were doing different protocols, looking at different things.
Different time frames. One study was 11 days.
Yeah.
So they did it for 11 days.
So there's a problem that in collapsing the data to do a meta. And so what we default back to is a systematic review. And you're exactly right that there were 6 included studies, and actually 3 of them were from the same author.
Yeah.
2 of them were within that same author, the exact same cohort, but they were published in 2 different journals. So technically, I would not have included them. It looks better, as you said, 6 versus 5 is a lot better looking on paper, but in reality, what you need to do is just conclude that as one source in those 2 because it was from the same cohort.
Sure.
Overall, the paper was really well done. And when we talk about systematic reviews, we like to use the PRISMA method of reporting guidelines. And that's one big thing I want to bring to these conversations as well is using quality appraisal tools, reporting checklists And these authors used Prisma, which is really good. And I went back and did a quality appraisal using something called an AmStar, which is to evaluate each point. And it scored pretty well in what they did. Another couple of things that I liked about this was they pre-registered the systematic review. So there's a database, if you've heard of clinicaltrials.gov, there's one for systematic reviews called Prospero. And you want to see those be registered beforehand so the authors can't go back and tweak things to make any changes. So overall, I thought it was well done. I think that they weren't able to do a meta-analysis. Thank goodness they didn't try, but I do think they should have been able to kind of collapse that data. And they still gave us, you know, some pretty good information. And to answer your question real quick about the international side, remember that this started in Japan in the 1960s as Katsu, and 3 of the included studies were from Japan. Right. And so that technology has been around for years and used safely many times around the world. It became, obviously, I remember looking at this as I was reviewing papers, grant applications for the American College of Sports Medicine. We had an annual Katsu grant that they actually provided, like a $10,000 grant every year to study Katsu through the ACSM. And so I was the same as everybody. This was, what, 10 years ago. What's that, right? It was being very popularly used in older adult training because, as Bob said, we can do lower load. Yeah. And that's where the geriatric population was benefiting all over the place. And then it gets quiet, and then all of a sudden pops up again when we see our veterans with amputations coming back and trying to use this. And it's really exploded. And I can agree with Bob more. You don't need a certification to do this type of stuff. It's great that you're trained and you know what to look for, because you can hurt someone with this. But that's the purpose of these papers that we write. We try to make sure that everyone is understanding the safety behind it. The mechanism is still a little fuzzy for us. We believe it's about metabolic metabolites that are remaining in the area to stimulate muscle growth, but there's still a lot that we need to learn. So to answer your question, it's not great to have this low level of evidence. And the part of that is that balance, right? You give up a little bit of, we call it internal and external validity. So the more broad you are, the more heterogeneous, the less focused you are. So that's the problem that we run into. So
yeah, Bob, can you talk about the? It seemed a little, as I was reading it, trying to do a systematic review on this topic does seem a little messy, because you've got all these different, you know, they did it for different times. They used different protocols. They used different set schemes. They used different loads, really. What do we know about all that? Or is that still, I mean, we don't know, again, exactly what loads to use, what rep schemes, what, you know, all of that stuff.
Well, I think that I agree with you, Rob. There was a lot of variables that they reported on.
A ton of variables, yeah.
And it's kind of like the population I like, and Phil alluded to this, was I really like it in my older patients because you can use a lower load. So my total knee patients, we're going to only use a 20-30%, you know, 1 RM. And people say, well, how do you get to that 1 RM? Well, you can guess at it and start with a low load and work your way through it and see how the patient does, or you can use the contralateral side to determine it. You know, we've used it as upwards of on an 80-year-old with a quad tendon rupture. The one group I really think this could benefit, and again, I think the training has to be long. It has to be probably 8, 9, 10, 12 weeks. I don't think it's just, oh, here's a 2-week course, see how you do, and then you go on. There's no literature that supports muscle adaptation occurs that fast.
In 11 days, yeah.
And so I think that's where a clinician has to go back to exercise physiology 101 that they took back as a young student, and that we know that 6 to 8, 9-week cycles when we do periodization is critical. So we need to do these cycles for at least 8 weeks, in my mind. It's the younger patients with patellofemoral pathology who you can't load, because if you load them, they hurt. And if you look at the one paper I believe there's a paper out there that looked at BFR and pain, and the fact that it assisted with osteoarthritic pain, and also in patellofemoral patients. So we even had a patient which, technically we weren't supposed to do it on, who had chronic regional pain syndrome. And so supposedly the cuff would cause irritation of the saphenous nerve, and we would make her worse. But again, after her dealing with this for 18, 19 months, it was like, what do we got to lose? So, we tried it with her. We combined that with some other stuff, and we were able to lighten the load. And we were able to push through a 20-minute, actually we started her way down at like a 12-minute cycle and then worked it up. So I think that you as a clinician need to look at that patient that you have and what they can endure. One of my basketball players, we would get it on him after his second meniscus surgery, and man, he wanted to be in it all day long. It's like, dude, we got to just take it off. He's a big Russian kid, and everything in Russia is bigger and better if you do it longer. So we had to temper him, and he did very, very well with it, and actually came back. But we did an 8-week cycle, and I think you have to take it out like a typical training session you would have a periodization. It isn't just 11 days. It isn't just 2 weeks. Keep with it for a while, because I think the patient will get more benefit.
Great. We've just got about 5 minutes left, and someone on the chat, Bob, put a question for you, I think, something about the New York State Board ruling on BFR. Did you want to comment on that at all?
I knew that would come up at this point. I have no idea. Actually, in our little ICAS chat we had today, I noticed that somebody from the New York State was saying how it evolved, and I was kind of surprised at the fact that the board did that. Being that I think Phil pointed out, every article out there basically shows it's safe.
Yeah.
There's no, within our company, we track these type of things in terms of for our risk management department, and we have more risk management issues with dry needling than we do with BFR. And so I think that for the New York board, and again, not knowing the makeup of the board, not being critical of the board, but for them to make this arbitrary decision, because my understanding is other professions within the state are not restricted from
That's what it sounded like.
So the question becomes, why did they just say, hey, this group, can't do it? And I kind of really, I think somebody needs to question the board. I think somebody needs to go and say, show us the data you used to make this decision.
Exactly. I'm guessing it'll happen.
Obviously, with the number of complications that can occur with other things we do, why did they select out BFR? And I quite honestly, me, I'll say my 2 cents, which is it's absolutely ridiculous that they would pick on that. And I think people in New York need to say, how did you guys get to that decision? Because the data certainly does not support it.
Yeah.
Actually, just in that context, I had a study go through IRB a few weeks ago, went to full review, because some people on the IRB didn't understand what it was. And once they found out, I'm like, it's been used all around the world safely, not a problem. And I am actually a member of the Louisiana Physical Therapy Board, and this puzzles me, because we take these discussions with evidence, and we, again, like Bob said, we don't know what happened up there. We're trying to find out the information. But you do have the ability to go in front of a regulatory board as a public member and state the case and get on the agenda. What you need to do if you're interested in this, and this, at least the way it works in Louisiana, is you send a letter to the board, say, I want to come speak to the board. I want to address this. I want it on the agenda for next month, or however it works. So don't give up. Keep asking questions, and use science, use evidence to support your arguments.
Yep.
I can't say that I've had, a knock on wood, that I've had a complication from the BFR. And again, we use it through a whole cross range of patients. So I think in certain pathologies, in my mind, if you got a pretty hot patellar tendon, if you've got a pretty hot patellofemoral joint issue, it is an excellent format to use so that you can use that low force, but yet accomplish the same thing as if you were doing high intensity.
Doing higher load, yeah.
Yep.
Yep. Good. Well, hey guys, thank you so much for joining. Unfortunately, we don't have time to go through all the question and answers, but I appreciate everybody sending in their questions for us. I appreciate Phil, you being on, Bob, you being on, Michael, you helping, and Ashley and Mike for setting all this up. I think this really worked out nice. I made up a list of questions I wanted to ask, and we got through maybe half of them. So it went way better than I thought it would.
Yeah, I think it was great. Thank you for hosting. And just a couple last quick reminders for those that weren't on in the beginning. We are attempting to get UC certificates. Again, that approval is just in the state of Tennessee. So depending on what your state requires, that may or may not be beneficial to you. But again, this is our first go at it. There may be some glitches in that system. It should be automatically sent to you. But if it does not happen that way, we will get them sent to you. And then just a few last quick notes I put up on here. If you just go to ijspt.org and sign up to receive emails about everything that's coming up. One of the things, I think Kevin's been on with us this evening, joining this group. So as a reminder, we're also co-sponsoring Kevin's Grand Rounds, which are also awesome educational opportunities. The next one coming up with Chris Powers is sure to please. And then the things that Phil mentioned earlier at the start, we did some educational courses that are available on our YouTube channel on clinical statistics as well as peer review. So if you guys want to follow our YouTube channel, it's there as well. And then any other questions that come up, feel free to email me. If you need to get in touch with these guys, you can go direct through me and I can help get the questions sorted out where they need to go. So any last comments?
Just thanks everyone for attending. We're planning on doing this again next month, probably toward the end of July. So just watch for flyers and emails and information about it.
Great. Sounds good. Thank you, everyone.
Thank you, Rob. Thank you, Phil. Thank you, Ashley.
Thanks, everybody.
Thanks. Have a great night.
Thanks for having me. Thanks everyone.